my name is Madeline Mumbert. My student ID number is 3251089. My semester is spring of 2020, and my class is veterinary surgical monitoring and anesthesia. And today, to start my video, I'll be going over checking in animals and going over all of their forms. The first thing is their check-in form, which has the patient's name up here and then the owner's name up here. So we're pretending that my cat Jack is here for a dental procedure. It'll show all the information about him. He's a 16-year-old male-neutered domestic short hair. And then over here under patient notes, it talks about any prior clinical history. So he had his right eye enucleated in February of last year, histoplasmosis in March of last year, and then he had growths removed from the top of his head that turned out to be calcium deposits in April of last year. If we go into our software, which is Client Tracks, this is where his permanent medical records are. They're all digital. This is his medical record for today. And then if you go backwards, it has all of the previous medical records. It also has his reminders for his vaccines over here in his patient card. And there's an attachment button for biopsy results and lab work and that sort of thing. Moving over here. When you're checking in a patient for a surgical procedure or a dental procedure, we usually provide estimates so that the owner can sign and so that they are aware and on the same page of what we'd be doing. So this is a mock example of a feline dental. We would also go over their anesthesia and surgical consent waiver, so we'd have them read through this and then sign on this page, releasing the animal to us, consenting to anesthesia, and if there are any additional extractions, they would sign for that as well. As far as patient identification, we have a couple of things that we do here at the clinic. We put them on our whiteboard, and so Jack is up here. This lets us know where he's at in the clinic, so he's in the ICU, his weight, what he's here for, which is the dental, and then over here we sign our initials for the technician and the doctor that will be working on the case, so that way if there's any questions about the patient, we know who to talk to. We would also take the same admission form and we would put it on their kennel so that we know where our patient is and what they're here for, so it would say dental. We also have little cards that we can erase and write new things on, like caution cards, or if we need samples to be obtained, we can add those to the kennel so that the whole staff is aware. Moving on. We do pre-surgical lab work for any patient that goes under anesthesia, so this is a copy of his. We provide this to the doctor that'll be working the case so that they familiarize themselves with their patient. There's minor elevations, but nothing that would keep him from going under anesthesia. We have our anesthesia monitoring log where we have their information, what they're coming in for, and then we mark these main categories here: drugs that we use to induce them, monitoring all of their vital signs while they're under anesthesia. We like to keep track of when surgery starts, when anesthesia starts, and then vice versa, when surgery stops and when anesthesia stops. We also keep track of their recovery, and then any additional notes is where we put IV fluid rate, pain injections, that sort of thing. So I included an example of a patient that was in last week where we monitored and then wrote down some additional notes down here. And then the last thing is his discharge that we put together. So this would go over, if I were talking to the client, I would say Jack was here today for his dental procedure. His exam checked out normal besides his dental health. There was a slab fracture on one of his teeth, so the tooth was extracted due to exposure of the pulp cavity and risk of infection. You know the tooth number also, so that it makes it easier for the owner to appreciate what was done. It talks about the lab work being normal, the tooth that was extracted, and then some at-home care instructions. So if there are extractions, we usually recommend feeding soft food for a couple of days and then sending home pain medications. The pain medication that was selected for him is Onsior, which is a pain reliever and an anti-inflammatory. In this, it suggests waiting until tomorrow morning to start his pain medications because we gave an injection today. Some side effects to be aware of for Onsior is it can cause some mild GI upset, and it can also cause some kidney problems, but we know that our patient does not have any pre-existing kidney problems, so Onsior would be a good choice for them. There's a brief synopsis about oral surgery, and then we recommend having them come back in 2 weeks for reevaluation, A, because they were under anesthesia, we want to make sure they recovered from that, but B, to check the extraction sites, check on the sutures, make sure nothing gets stuck, and that they recover properly from their anesthetic event. Okay, now I will be demonstrating restraint for a blood draw on a canine patient for the cephalic, jugular, and the lateral saphenous veins. We'll start with cephalic since he's already sitting pretty in sternal recumbency. So to do this, I'll position my body behind him so that he can't back up. I'll use one hand to kind of hold his head out of the way for whoever's drawing blood. It's okay. And then I will extend his limb forward, supporting the elbow. His cephalic vein runs along the dorsal aspect of his front limb here. And I'll occlude the vein by gently rolling and applying pressure with my thumb so that they can draw blood this way. While he's also sitting in sternal recumbency, I will do the jugular restraint. So we'll keep him sitting, but we'll position his head upwards, exposing his jugular, which runs along here and here, and then move any leashes or collars out of the way. Again, keeping in mind that his head needs to be positioned away from whoever's drawing blood, and then my other hand can keep his limbs placed down so that he doesn't paw at them while they're trying to draw blood. Lastly, for the lateral saphenous, they'll be in standing restraint. So I'll keep one hand and kind of position his head away. I'll keep my body pressed up against him so that he doesn't want to move in any direction. And then the saphenous vein on the lateral aspect runs along this side of his leg here. So to occlude the vein, I'll apply pressure up here so that the vein pops down there, and then just keep control of him the whole time. And that's it. Okay, now we will be demonstrating restraint for blood draws on a cat for the cephalic, jugular, and saphenous veins. The first one that I'm going to demonstrate is the cephalic. So we'll have our patient sternal, and the cephalic vein runs along each front forelimb here on the dorsal aspect of the limb. So what I'm going to do is keep my patient sternal, restrain him with one hand, so I'll do a light scruff. And with my dominant hand, I'll extend his elbow forward, which is exposing the vein, and then I'll occlude the vein here. I'll be sure to keep my body behind him so that he can't escape during the blood draw. For jugular, you can keep him sternal as well, and so you just lift his head and expose the jugular here for your blood drawer. You can also put them over the table. And extend the limbs down to get better access to the jugular vein. You can also do a jugular blood draw on their side laterally. So I would hold these limbs out of the way and then push his head up, which would give you access to the jugular vein that way. Lastly, for a medial saphenous blood draw, I would put them in lateral recumbency again. Have one hand on the scruff. Keep my limb back here, my arm back here so that he has his back supported. And then I would lift his top leg and his tail out of the way, occlude the vein by pushing down here, and then my restrainer would pull this limb back and draw blood from the medial saphenous vein, which runs along the medial aspect of each rear limb. Okay, now I will move my patient in and out of a kennel. So when I move him into a kennel, I'll just walk him in. There's no pushing or any sort of activity like that. It's just kind of gently guiding him with the leash into the kennel. I'll take his leash off while he's in there. And close the door behind him. You want to make sure that you lock your patient in the kennel so that they don't accidentally or purposely open it. And then to take him out, I'll kind of dangle my leash in front of his head so that I'm not like impeding his space. So I'll just kind of dangle it, let him walk into it, and then walk him out of the kennel like that. Okay, now I will be demonstrating how to safely apply a dog muzzle. I have somebody restraining for me, and then I've also selected the appropriate size muzzle for your patient. You don't want it to be too loose, obviously, because then they can still bite you, but you also don't want it to be too tight to where it's uncomfortable, because that can make them more reactive in that case. So to apply the muzzle, I usually like to stand to their side instead of coming straight on at them. I'll hold the muzzle as if it would be worn by the patient, and then I will slip it over his snout. And then I will buckle behind his ears. And then make sure that it's snug, not too tight, but snug enough to where he can't just paw it off. And that's it. And then to take it off, I'll just unbuckle it and release it. Okay, now we'll be applying an e-collar to a canine patient. This is Buster. I've selected a 20 centimeter e-collar for him. So to apply this type of e-collar, you can just wrap it around their neck and adjust it from there. So I'll wrap around this way, pull it together, and then clamp it closed. So I know that this is the right size e-collar for him because it extends past his nose. So that way if he's trying to lick or chew at something, he won't be able to access it. I also can slip 2 fingers underneath the e-collar, which tells me it's not too tight to where it's restricting his breathing or make him uncomfortable. It's also not too loose to where it just budges over his head to where he kicks it off. So it's the appropriate size e-collar, and it's been applied correctly. And then to take it off, you just unclamp and it releases. Okay, now I will be demonstrating a physical exam on a canine patient to ensure that they're ready for anesthesia. To do this, I'll start by obtaining a TPR, which is temp pulse respiratory rate. I have a loop thermometer here, so I'll start by getting his temperature. I'm sorry. Anything between 99 and 102 is usually a normal temperature for a canine. And his temperature is 101.1, which is normal. And then we'll move to his pulse and we'll take a listen to his heart. You want to listen near the axilla area. So his heart beat 15 times in 10 seconds. I'm keeping an eye on the clock over here. If you multiply that by 6, then you get a heart rate of 90 BPM or 90 beats per minute. Take a listen to the other side. I'm also listening for any abnormalities, like I mentioned earlier, any sounds that would indicate a heart murmur or any irregular intervals that could indicate an arrhythmia. I'm not hearing any of that with him. Heart sounds good. Then we'll move on to his respiratory rate and continue to listen. I'll listen for another 10 seconds. So he's panting, but it was approximately a breath per second. So that would be a respiratory rate of 60 BPM or 60 breaths per minute. Normal if they're nervous. But we're listening to each quadrant of the lung again to listen for any abnormal sounds, any crackling or wheezing, anything that could indicate asthma, inflammation of the lungs, fluid, that sort of thing. Okay, everything sounds good. Take a look at his coat quality and his skin. Skin is a nice pale pink color, no indication of any parasites, shiny coat. Palpate his abdomen real quick. Good boy. Everything feels where it should be. He has no testicles because he's neutered, but you would want to feel for that. Taking a look up here. His ears are nice and clean. Another pale pink color. No inflammation or infection. His eyes are nice and bright and clear. No discharge there. No discharge in his nose either. His teeth have very mild tartar buildup. He's also a young patient. His bite lines up nicely. So overall, he's young, he's very healthy. We would give him a grade 1 on the ASA scale also. Another good candidate for anesthesia. Okay, now we will be demonstrating a physical exam on a cat. So the first thing I will do is obtain TPR, or temp, pulse, and respiratory rate. I have a loop thermometer here, so I'm going to start with the temperature. We've already got her weight. She's about 15 pounds today. She's been living at the clinic for a couple of years on a weight loss program, so she's lost quite a bit of weight already, but still has a little bit of work to go. So her temp is 101.9, which is normal for a cat. So we'll get her pulse now. We'll auscultate her heart. And I'll watch my clock over there. So her heart beat 20 times in 10 seconds. So if I multiply that by 6, then I'll get a heart rate of 120 BPM, or 120 beats per minute, which is normal for a cat. I'll listen to the other side to listen for any abnormalities. Any swishing sounds can indicate a heart murmur, and you should let your doctor know. And the intervals between each beat should be equal, which hers are. If they're not equal, then that could indicate an arrhythmia. Next, I'll listen to her respiratory rate also, so we'll auscultate each lung field. And they have 9 quadrants on each side, so you just need to listen to each of them. So she took 6 breaths in 10 seconds. So if you multiply that by 6, you get 36 breaths per minute, or 36 BPM. I'll listen to the other side. You want to listen for any wheezing, crackling, popping sounds that could indicate pleural effusion or fluid. But everything sounds clear there. Next, I'll evaluate her coat quality and her skin. She just has mild dander, but that's because she obviously cannot groom herself very well. We'll do a quick palpation. Obviously she has a lot of fat deposits still, but she's still working on her weight loss. There's a moderately full bladder. Everything feels like it's sitting where it should be. And then moving to the front end, take a look in her ears. Mild wax buildup, but no signs of any inflammation or infection in each ear. We'll look at her eyes, just a mild ocular discharge. But the scleras of her eyes, or the whites, are white, they're not red. Her pupils are the same size. Her nose is clear of any discharge. And take a look at teeth also. You want to make sure her bite is aligned. She's very minimal tartar, but she's also a very young cat too. She's not missing any teeth now. So overall, she seems, besides her weight, like a very healthy patient. So she would get a grade 1 on the ASA scale, and she would be a good candidate for anesthesia. Okay, now I'll be demonstrating a blood draw from a canine patient's cephalic vein. The cephalic vein runs along the dorsal aspect of each forelimb, so I will have my restrainer occlude the vein for me by holding off. And then I will use a 3cc syringe with a needle on it already to draw my blood. The first thing I'll do is wet the area with some alcohol. This will sterilize my area, but will also help me visualize the vein through all of his hair. I'm going to insert the needle, pull back on the plunger, and then when I'm done, I'll let my restrainer know so that he can apply pressure where I drew the blood so that he doesn't develop a hematoma. And there's our blood sample. Okay, now I will be demonstrating a jugular blood draw on a canine patient. My restrainer is holding him in sitting sternal recumbency. He'll hold his head up out of the way so that I can feel his jugular vein, but I'm going in with the same 3 cc syringe with a needle attached to it, and then I'll apply alcohol first to sterilize my site and help me visualize his vein. I'll occlude the vein by pressing my fingers down into the jugular groove. It's okay, buddy. Pull back. Then I'll have my restrainer hold off so he doesn't develop a hematoma. Oops. Recap my needle, and that's the blood sample. Okay, now I will be demonstrating a blood draw from the lateral saphenous vein on a canine patient. Paxton is back, he's doing very good. He's in standing restraint. My restrainer will occlude the vein for me here shortly. I still have my 3 cc syringe with the needle on it, and then my alcohol. So this will, again, sterilize my site and help me visualize the vein better. And I will hold my other thumb here to keep the vein from rolling, because it can do that sometimes, so we'll keep it stable. Pull back on my plunger, have my restrainer hold off so that he does not develop a hematoma, and there's our blood sample. Okay, now I will be demonstrating a blood draw from a cephalic vein on a feline patient. This patient is obviously anesthetized. To do this, I'll have my alcohol, which I will use to sterilize my site, but also help me visualize the vein. And I have my restrainer occluding the vein for me. And then I will use a 1 cc syringe with a 25 gauge needle, a super small needle, because cat veins are smaller. Okay, when I'm done pulling blood, I'll hold off where I drew blood and then have my restrainer hold the arm for me. That way a hematoma does not develop, but that is my blood sample. Okay, now I will be demonstrating how to perform a jugular blood draw on a feline patient. This is our patient. He's been sedated for this procedure. I've already shaved a window here so that I can help visualize the vein better, but the next step is to prep the area with a little bit of rubbing alcohol. That will help sterilize my site, but will also help me visualize the vein better. I have a restrainer too to help hold the head out of the way. I'll go in with a 1 cc syringe and a 25 gauge needle. Cats tend to have smaller veins than dogs, so we'll use a smaller needle. And then I will occlude the vein by pushing in to the jugular furrow. And when I visualize the vein, I'll insert the needle. When I have my blood sample, I'll let my restrainer know so they can hold off so he doesn't develop a hematoma. And that's our blood sample. Okay, now I'll be performing a blood draw from a medial saphenous vein on a feline patient. Our patient has been sedated for this procedure. The medial saphenous vein is located on the medial aspect of both rear legs, so it runs down the middle here. I'll have my restrainer occlude the vein for me and hold the up leg out of the way. And then I will go in with some alcohol to help me visualize the vein better and kind of sterilize the area. I'm going in with a 1 cc syringe and a 25 gauge needle. Once I've obtained my blood sample, I'll have my restrainer hold off so that our patient doesn't develop a hematoma, and that's our blood sample. Okay, now we will discuss the databases that we use to prepare our patients for anesthesia. The minimum databases required are a CBC, which an example of is right here. This evaluates mostly white blood count, red blood count, and platelet count. It also evaluates hematocrit, so super important. It also continues here for any patient to go under anesthesia that we know their clotting ability of their blood, infection, possibilities of infection, inflammation, that sort of thing. They also require chemistries. So an example is here. This evaluates liver, so that would be ALT, ALP, over here as well. Kidney values such as BUN and creatinine, and electrolytes such as sodium, potassium, chloride. Those evaluate internal organ functions. Those are also the organs that metabolize anesthesia, so it's important to know that they are functioning well. Another minimum database is a urinalysis, so this will let us know the kidney function also is kind of a backup to evaluate kidneys, so it'll give us blood readings, a glucose reading, and then specific gravity of the urine also. It'll also let us know if there's too much filtering protein in the urine as well. At our clinic, we also require, as minimum databases for any anesthesia workup, we require a T4, which is a thyroid value. An example of a T4 here, this is within normal range. We also require heartworm tests, fecal tests, and cardiac proBNP values, such as this one. So 109 is higher than 100, but this is the normal reference range. So if we were to then proceed with anesthesia after these databases have been obtained, we can move on to additional testing, which can include radiographs, ultrasound, use of a Doppler for blood pressure readings, and EKGs. So for this patient in particular, we would encourage all 4 of those things. Since there is a increased cardiac enzyme, we would want to dive into that before we put them under anesthesia and know, is there just muscle fatigue to the heart, or is there active disease that's going on? Because the heart will be compromised when they're under anesthesia anyway, so we want to know how compromised it is. So we would encourage the ECG, thoracic radiographs to evaluate heart shape and size, an ultrasound to evaluate if there's any leakage, the muscle density you can see on the ultrasound also, and then Doppler obviously for blood pressure to see if it's high or low. So after all of those things are obtained, then we can have a better idea whether or not we should proceed with anesthesia. Okay, so now we will talk about the anesthetic protocol for our patient after we've reviewed all of the databases that have been obtained. For this patient, there is some noted heart disease, so we are anticipating that he will come in for a dental cleaning under anesthesia. We anticipate that it'll take about an hour altogether with him being under. So we would choose, and I consulted with my veterinarian prior to this, but we would choose butorphanol first to sedate him. We would avoid Dexdom because that drug has the ability to lower blood pressure, and that would decrease the amount of blood filtering through the heart and the kidneys, and so we still want that blood flow, so we would avoid Dexdom. We'd use butorphanol to sedate first, and then if the patient is not fully sedated at that point, we might add a little bit of propofol afterwards to induce him. Propofol is safe as long as it's in small amounts and you have your anesthetist breathing for the patient, as sometimes it can inhibit their ability to breathe on their own. Pain management wise, we would probably choose Buprenex as opposed to Onsior. Onsior is usually a drug that we use at the clinic, but we would avoid that with this patient. Since he has heart problems and early kidney problems, you don't want to use Onsior with a patient who has renal issues or dysfunction. We would choose Buprenex, and that would make sense for the procedure because the injection lasts anywhere from 6 to 8 hours. So that would give time for the patient to recover and then resume medications at home. And that's it. Okay, now we will be filling out a mock controlled substance log. To do this, I'll be using propofol as my drug of choice. So on the form here, we'll fill out our drug, which is propofol. Propofol is a class 4 drug. It comes in the injectable form, which is what we'll be using. The strength is 10 mg per mil on this box, and they come in 20 ml vials that are used for multiple doses. Today's date is 2/26/2020. We'll pretend that we're using it on my cat, so Jack, and then we'll fill out the owner's information. So name and address. And then it asks for a client ID number. That's mine. Species, he's a cat. And we'll pretend that we use the propofol for induction into anesthesia. Normally, we might pull up 1 ml of propofol after already sedating him with some butorphanol. And if he, for example, was already sedated enough, we only administered 0.5 mils, then we would have another 0.5 on our balance. And we would not use that again for another patient because chances are there's blood mixed with that drug from pulling back on the plunger. So we would waste 0.5 mil. So after filling that out, I would have a veterinarian sign to authorize that in the log. And that's how you enter a drug onto a controlled substance log. Okay, now I'll be going over our anesthesia machine. This is one of the ones that we have here at our clinic, and I'll kind of go step by step through each part of the machine. To start, I'll go over our oxygen tanks. We have E tanks here. E stands for emergency. There's also H tanks that some clinics have, but we don't have those. Those are the big tanks that lead into each room. H stands for huge. But our oxygen tank is here, and so if you turn this on, lefty-loosey, righty-tighty, you can come and see the valve. So this has about 1,000 psi in our tank, so that would be enough for a couple surgical procedures. And the oxygen flows from this green tubing here. And so the next thing to look at is our O2 meter. And so this looks at how much oxygen is flowing through your machine. And so most procedures are run between 1 and 2. This is in liters. And so the ball is letting you know, like, this is 1, not this or this, but the ball has to be right on the 1. And so the oxygen will flow into either our vaporizer or it'll bypass the vaporizer and go straight to our reservoir bag. To bypass the vaporizer, you hit your O2 flush valve. And so you'll hear the oxygen just going, it's bypassing straight through this and into the oxygen, or into the reservoir bag. So if you want to give your patient just pure O2, like if they're in recovery from an anesthetic procedure, then that's when you use this. If it's not bypassing, it's going through here into our vaporizer. And so this takes your liquid anesthetic, which we use isoflurane here, and it vaporizes it and mixes the liquid with the oxygen and becomes the anesthetic gas. So if you look here, this shows you how much isoflurane is in your machine. And so this is considered enough, but up to the line would be totally full. But this vaporizes, and then you can pick the percentage that you want. So it goes anywhere from 1% isoflurane to 5%. And it'll mix and it'll flow into your tubes. So we have an inspiratory valve and an expiratory valve. This is a rebreathing machine, so how it works is when you hook your patient up, whether it's to an ET tube or a mask, they inhale through this tube and exhale through this tube. So some advantages to this are preventing hypothermia because the breath that they're breathing out is warming the breath that they're taking in. A disadvantage to this is if you have a small patient, it takes more effort to breathe through it. So in that case, you would want to use a non-rebreathing system. We don't have one of those at the clinic right now, but that would be advantageous for small patients because it would be less resistance. But on the other hand, it's a higher risk of hypothermia because you don't have the reheating element to it. Rebreathing systems also use less oxygen and gas, but non-rebreathing systems use more of that because they don't recycle. Since this is a rebreathing machine, it recycles our CO2, and so we have a CO2 canister here. They will absorb the CO2 and it'll do one of two things. It'll, color change will take place, and so it's white right now, but it'll turn to a lavender color if it's exhausted. But you want to be careful because if you don't watch the color change happen, it can go back to white without you realizing it. Another way to determine if it's been exhausted is by crushing it. If it's crushable, then that means it's still good, but if it's like a rock hard pellet, then that means it's been exhausted. Another part of our scavenging system is going back through here. We have an absorbent canister down here, and so this will gain 50 grams of weight when it's fully exhausted, and so that's also taking extra gas that is not being used and is going into the canister. If we are not using an ET tube, which an ET tube would hook up like this, but if we were not using this for whatever reason, we have masks that can hook up instead. Perhaps for a feline patient or a patient that you don't need to intubate, you're just gassing them down for a short period of time, then you would use the mask, and then there's different sizes too. There's also induction chambers that are used. We don't have one in our clinic, but it's basically a sealed box that you pump the anesthetic into instead of intubating them or using a mask, and then they fall asleep that way. But this is basically the machine as a whole. You don't want to forget your manometer, and so this reads centimeters of water. When you're breathing for a patient, you don't want it to go over 20 because that can cause harm to the patient's lungs. And this specific machine has this safety feature here, this button, so when I press it, it's temporarily, it would be the same thing as me shutting off this pop-off valve so that you can give your patient a breath. And then when you release it, it's like the pop-off valve is opening and it opens everything back up again. But if my machine did not have this button, then I would have to close the pop-off valve and then open it every time I'm giving a patient a breath. This is the pop-off valve. So it closes so that you can leak test your machine and then have everything pass through, and then you open it back up to let the pressure release. You always want to remember to open this back up, otherwise pressure can build up and it can expand the lungs too much. It could even cause death in your patient. So yeah, that's our anesthesia machine as a whole. Okay, now I'll be demonstrating how to leak test your anesthesia machine. I have everything already hooked up to the machine, so I have the anesthetic circuit hooked up and the reservoir bag. So after I have everything on my machine, I'll turn my oxygen on. And then the first step is to turn off the pop-off valve, or close the pop-off valve, rather. And then we will occlude the end of the circuit, so you can do this with the palm of your hand or with your thumb. And then we'll flush some oxygen through on the O2 valve until the manometer reads 20, and that reads centimeters of water. And so you want it to read at 20 and stay at 20, which it's staying, so that means there's no leaks in the system at all. And then I'll go ahead and open the pop-off valve back off, and it goes to 0, so that means everything has escaped the system, and it's able to leave and not have pressure build up. You always want to make sure that you open this back up after you have closed it, so usually before walking away from the machine, I just keep my hand on this to make sure that I remember to open it back up. And then I'll turn the oxygen off, and our machine is ready to use. Okay, now I'll be demonstrating the placement of an IV catheter in a cephalic vein of a canine patient. This patient has been sedated and he's about to be hooked up to anesthesia. He's wearing a muzzles for protection of myself and my restrainer. This is Dr. Lisa Hansen. She's my preceptor, and she'll also be holding the dog for me. So I'm going to start by taking my front arm and shaving a small square where the cephalic vein should rest. And I already have my supplies laid out here, so I have some chlorhexidine scrub and some alcohol, so we'll go ahead and clean our site next. So you want to start at the center and clean outwards, so that the center is your most sterile area, your most clean area. And I'll kind of rotate between chlorhexidine, alcohol 3 times at least. If it's a really dirty patient, you can go 10 times and that would still be okay as long as your area is clean. Okay, my restrainer is occluding the vein for me, so that I'll be able to see it. Next, I'll go in with my catheter, and I'll insert bevel up into the vein. Once I see a flash of blood, I'll advance my stylet, and I'll let my restrainer know to hold here so that the blood doesn't flow out. And I'll attach my T-set. Okay, and then I'll go in with my first piece of tape, so skinny tape, sticky side up. The next piece of tape is a bigger piece, but it has a notch in the middle, so we'll slide that underneath. Our third piece of tape is another skinny piece, but we're gonna make a notch in the middle so that it can wrap around like this. And the final piece of tape is a big piece of tape, and that will wrap the T-set across and secure that. Okay, and then I'll make sure my catheter is patent by pushing some flush through, and it's flowing easily. So I'm going to now take my male adapter plug and attach that. Also going to close off my T-set. So the catheter is ready for use, but since we're not going to use it right away, I have a piece of vet wrap that I can use to sterilize or keep it clean until it's ready for use. And that's it.
Well, yeah, it doesn't sound like
Okay,
they're
now I will be
growing
demonstrating
and causing
placement
a
of
lot
an
of
IV
problems.
catheter in a lateral saphenous vein of a canine
So,
patient. This is our patient. She's been
one of
sedated.
the things,
She's ready to be anesthetized, so she's in lateral recumbency.
in
The
using
saphenous vein
prednisone,
runs
he's on
along this part
for
of their
the
leg
arthritis.
here. So I'll
And
start by
you
shaving a
can't
little
do
square
both.
where the vein
Yeah,
is.
it's one or the
My
other.
preceptor,
So,
Dr. Lisa Hansen, is
right
here.
now,
She's
I think
going to
it's
restrain the
arthritis
patient and
is
include the vein
probably
for
more of an
me.
issue.
So I'll start by
I'd say
shaving.
let's, he's still eating fine and all. Let's just
She's got
stay
pretty
on
short
the
coat
development
anyway.
That we can put up the prednisone. It's just, when we start that, we'll have to stop the
And then I'll go
galloping.
in and start cleaning my site. So I'll start with some
You
chlorhexidine
stay with the
scrub.
gabapentin, that's not a problem.
You want to start at the center where you're going to place the catheter and work your way outwards
We can also add
so that the
some
center is the
tramadol.
cleanest part.
The tramadol doesn't
We'll
work
rotate
for all
between
dogs.
Chlorhexidine and alcohol and do that a minimum of 3
Probably
times.
actually maybe 1 out of 3 dogs. Well, that's
But if the
provides
patient is still
some
dirty,
pain
you are
relief,
welcome
but we can
to
use that in
rotate more.
addition, to the gabapentin and the prednisone to try to make sure we give as much pain relief as possible. Okay.
Once my area is clean, I'll have
Okay.
my restrainer include the vein for me.
Appetite primarily, yeah, because we're using the external lymph nodes, ones you can on the outside of the body, but there's ones inside the chest and inside the abdomen, and those are doing the same thing.
Once I locate my vein, I'll insert the catheter bevel side up.
That's where appetite may be impacted. So if capitate starts to go, then let's start on the prednisone. Let's discontinue the Galliprant, and then start with the tramadol at the same
Once I
time.
get a flash, I'll have my
And the
restrainer hold for me so
prednisone,
the blood doesn't
it's
continue to
not a
flow.
direct pain medication,
And
but
then I will
it's,
attach my
it's
T-set.
very potent anti-inflammatory, and it may give some pain relief for the arthritis.
And I'll start with my
indirectly,
first piece of
reducing
tape,
inflammation.
a
So,
skinny piece of tape with the sticky side up.
okay.
The second piece of
Yeah,
tape is the
continue
thick
with that,
piece with the
for
notch
sure.
in it
Yeah.
to secure the T-set.
But
My third piece is another skinny piece. We're gonna twist it in the middle to secure the T-set again.
as long as he's going,
And the
just
last
treating
piece
normal.
is a full piece of tape, and we're gonna
And
use that
he's feeling
to
fine, I'm sure, right now.
secure this
other than the
extension line.
arthritis. So, but I tell you what, if you want to just call back and pick up Fred later, or I can
flush
just put up
through.
for you now.
It's patent, so I'll take my flush
Yes,
off.
you stop out, pick it up, and you just hold on to it right now.
And
The
apply my
arthritis
mill
is
adapter plug
more of an issue, and the Galliprant.
And then close off our line until it's ready to use.
So,
We will
I'd
also
like
cover
to
it with a piece of vet wrap until it's
ready.
ready to keep it as clean as we can.
Okay.
And that's it.
Okay.